Hi, I'm Professor Sherry Wren from Stanford University. I'm excited to be coming to you today. I am in Krakow at the International Surgical Society, and I'm going to be sharing with you a presentation that I was asked to give by Dr. Andrew Hill, who's the president of the society, in his session on global surgery. So what I've decided to talk about today is how we need to engage women into the surgical workforce to be able to address the needs of the population. I've made this logo here that women hold up half the sky, which was actually adopted from a saying from Mao Zedong about how women actually are necessary to have a functional society. So there's a lot of workforce challenges right now in surgery. The global population continues to increase. People are living longer. Surgeons are aging, and a lot of the workforce in surgery is actually above the age of 50 at this point in time. There's this distribution of workforce more to rural areas and less to more to urban areas, and less to rural areas. And with the increase in the non-communicable diseases over communicable diseases, this is leading to a lot of stress in the system. What you can see right here is that this graph shows the total burden of disease caused by the world. And this pink bar right here is actually communicable diseases. And you see from going from 1990 to 2017, this is getting thinner and thinner as we control diseases like malaria, TB. Injury is actually staying fairly common, but non-communicable diseases, things like cardiovascular disease and cancer, are really on the rise. This is the number of people, but with cancer now by age. And what an incredible growth that you see over time. When you look at the disease of cancer, and I'm a cancer surgeon, almost every cancer is treated, diagnosed, or influenced by surgical management. So it's going to be a critical development to be able to care for the world's population to develop surgery. So this worldwide increase in cancer, diabetes, cardiovascular disease, we now are showing that 59% of new cancer cases are coming from low and middle income countries. People are living long enough to get cancer now. And then this global estimate that we need 321 million inpatient procedures to address this global burden. And the vast majority of these are going to be for non-communicable diseases. I think everybody is very familiar with the Lancet Commission heat graphs, showing that the density of surgeons from around the world, that there's significant deficits in sub-Saharan Africa and Southeast Asia. And that to reach these 2030 goals of adequate surgical coverage, that we're going to need to more than double the surgical workforce. This is an unattainable goal. And especially if we don't engage half of the population, which is women. So we have to bring women into the workforce. Even doing that, we're still not going to be able to achieve this goal. So what I'd like to do right now is kind of take you on a view around the world about surgery. So Nigeria. Nigeria is the most populous nation in Africa. It has more than 200 million people. It's the 7th largest nation in the world. They had their first woman consultant surgeon in 1977, and in a recent paper in 2017, they showed that they could only find 60 women surgeons or surgical trainees throughout the country. COSEXA, which stands for the College of Surgeons of East Central and Southern Africa, has actually made women and gender equity a key priority. And they have these really interesting maps that not only look at what is the density of surgery, but what is the number of women. And you can see here, this is the COSEXA region, that for Tanzania and Ethiopia, quite significantly large countries, there's less than one surgeon per 10,000 people. If you look at the amount of women, percentage of women in the workforce, this is also an incredibly small percentage. So how can we address the needs of these nations without increasing the amount of surgeons? You could say, is this just a developing world issue? But I'm going to say it's not. The U.S. is projecting significant surgical deficits in multiple specialties. When you look at England, this was just published in the British Medical Journal that there's a staffing crisis. And when you look at surgery, for 66 million people, there's only 12% of their consultants right now who are women. we are missing an entire group of people who could be helping. So what's the pipeline? Are there enough women? And I would tell you that in almost every country there is enough women. These are the statistics from the Aga Khan University. Almost half of their entering medical students are female. And you can see that, unfortunately, as they go and get to surgery, you're getting this significant drop-off. The same is true in Germany, where more than half of the students entering into medical school are female. But when you look at the number of German surgeons who are women, again, you see a paucity of people engaging in surgery. How about the United States? You would think we'd be doing very well. We're a country of almost 330 million. We have 50% of our graduates medical school are women now. But when you look at postgraduate trainees, we are still lagging behind and not achieving equity. People say, oh, well, women drop out. That must be why we don't let them in, right? We train them, they're not going to be there. What this graph shows you is that these small bars are the percentage of U.S. trainees in general surgery that drop out, and there is really no difference between male and females. What are these barriers? Why is this happening? Why aren't we seeing 50% of women going into surgery? And there's really, unfortunately, active discouragement. It happens in the medical school level, it happens at the training levels. There's a hidden curriculum that gets told. There's perceptions that women can't be surgeons if you want to have a family. You need to be strong and have physical and mental strength. It's a boys' club. And there's still, unfortunately, both active and passive discrimination against women. There's this whole saying now that people have to see it to be it, and that until you really reach about 30% of your workforce as being female, it's perceived as a male profession. These gender and social stereotypes and expectations have to be addressed, and we have to address conscious and unconscious bias. So let's look at Japan. Japan is forecasted to be the oldest society in the world by 2035, and they're going to have a significant physician shortage. The percentage of female doctors in Japan is the lowest of any of the OSED nations. It's a large country, and only 5% of their workforce is female. So who's going to be taking care of these patients as they get older? Japan was just rocked by a scandal in the last year. Talk about active discrimination. It was shown now that in up to 10 medical schools that the admission scores on tests by women were multiplied by a factor which made them not eligible to come into medical school. This was active discrimination. And now Japan is having to face this. So what are these barriers? Women tend to be isolated. There's a whole lot of less likely. They're less likely to be included in informal social gatherings where networking occurs, where you meet key people. They're less likely to be included in collaborative research, which helps in their academic productivity. They're less likely to have mentors or sponsors, to be given advice about how to navigate, and to be invited as speakers in panels. They also report unsupportive work environments, unclear rules about advancement, dysfunctional behaviors, and advancement opportunities are lacking. All of this is contributing to a dropout that we see as people move into the system and they leave the profession. So let's talk a little bit about unconscious bias. What is unconscious bias? It's different than overt bias, where you say something and you recognize that you are, or maybe not recognize that you're saying something. Unconscious bias is beliefs that men and women are expected to behave differently. And what's very interesting is that you'll be judged negatively if you break this role, and this works for both men's and women's roles. This can affect gender promotion and candidate pools, and both men and women have the same biases. So this comes into examples. So men are almost twice as likely to have a sponsor than women are. And what this results in is this lack of support and the holding back. And this happens to women in surgery. This is a fascinating set of data that was a economics thesis by a student at Harvard who looked at whether primary care physicians changed their referral patterns to surgeons based on either very positive outcomes or negative outcomes. And what they showed is that Referrals to male surgeons did not drop if a patient that they had referred died, but to women almost went totally flat. And if there was a great outcome, referrals actually went up for men. So you can see that, again, there's this tax almost on women and these referrals, and why is this happening? So surgical societies, which is a place where we could really make a difference, should be playing an active role. And this is a paper that I think has been published, where they looked at 6 large United States surgical societies, looked at how many women were invited, how many were keynote speakers, and whether they had all male panels, or otherwise known as manels. And they looked at them over time. And what they really saw was that in half these societies, they still had no plenary or keynote speakers over this 5-year time difference. 2 of them had actually really taken this on, had changed, had a significant increase in speakers and decreases in male panels. I surely hope that with Francis Collins now coming out with the National Institutes of Health saying that no NIH scientist will engage in a meeting that has all male panels, will help to change this further. Family responsibilities is where everybody talks about with women. We know that men are less likely to have spouses with full-time careers, and women sort of oftentimes bear the brunt of family, not just children, but also elder care. And this needs to be taken into consideration when thinking about women's issues. So what about some strategies? We could complain all we want, but what do we do about it? So we need to take action, both men and women. We need to address these issues. We need to engage with enlightened men who are going to help us. We need to create plans. We need to collect data. We need to encourage women students and residents. We need to address overt discrimination. And we need to make gender equity really a goal for our departments, our societies, and work on that now. So I would say the American College of Surgeons has done this well. It was established in 1913. There weren't women surgeons in 1913. They didn't really start coming around in abundance until after the 1970s. So we've now had 4 women presidents who are, you can see, it took 92 years to the first, but now we're having increasing numbers of women presidents. This is a very public face to gender equity. This is changing the landscape in the United States. This is the pictures of the 21 current chairs of surgery in our 281 academic departments. And I think that this goes a long way to saying, okay, women can be leaders and can be department heads. I think there's some spotlights. The Royal College of Surgeons of Ireland is really introducing measures to introduce and change these gender imbalances. The Royal Australasian College of Surgeons did a study, found out that bullying and harassment was a real problem there and is now addressing this. The College of Surgeons of East Central and Southern Africa has this actually in their vision statement, that it's going to be a meritocracy supporting everybody regardless of any characteristics. These are public goals, and when you're held to public goals, things can be changed. There's lots of things, lots of groups now. As many people know, I like to work a lot in Africa, so I'm very proud of the groups like Women in Surgery in Africa and the DREAM, the students' organizations, all there to promote women coming into the field. Effective advocacy, we have to do our part. We need to nominate women. We need to have women be visible. So thank you for the opportunity to be a visible woman today. We need to develop them. We need to engage along the way. I think one of the best things that we have is we have a lot of male advocates for us, and this public He for She, which is a WHO program, where men are also standing up and bringing women into the forefront. So I think the number of surgeons, if we don't engage with women, we're not going to be able to take care of the health of our nations. And we've got to recruit them. We've got to recruit them into our specialties. We have to develop them along the way. And the status quo is not an option. We need to actively make these changes. And I think that surgical societies such as this should lead the way. I look forward to see the first woman president of the International Surgical Society at some point in time in the future. So thank you very much for having this opportunity to share this message with the Lifebox people today.